All right. Good evening, my dear students. How was the exam today? I know there must be mixed feelings always after an exam. And specifically, I wanted to know how was the physiology part. It was definitely doable, good questions, most of which are covered in your classes. But we can go over these questions once again. So let's see this. Let's see the first question which has been asked, and that is the insulin independent absorption occurs in all of the following except. Now, herein lies the importance of reading the question carefully. So this is saying insulin independent. So insulin independent absorption occurs in the RBCs, in the pancreas, in the brain. Insulin dependent absorption is in the adipocytes as well as the muscle cells. Insulin will increase the number of GLUT4, which are insulin-dependent GLUT, in the adipocytes and in the muscle cells. So this should have been a very simple question, right? So yes, I'm sure most of you must have got it right. All right, let's look at the second question. It says that the adjoining graph shows the effect of parathyroid hormone on the blood calcium and phosphate in an experimental animal. So here you have parathyroid hormone, which was administered to an experimental animal. And what do we see? What happens to the plasma calcium levels? The plasma calcium levels will increase and the phosphate levels decrease. And this is because what is the effect of parathyroid hormone? Parathyroid hormone has an effect on the bone and on the kidney. On the bone, even though the receptors for parathyroid hormone are on osteoblasts, but it causes a secondary increase in osteoclastic activity. So it does increase the osteoclastic activity. What is the role of parathyroid hormone on the kidney? On the kidney, it causes a decrease in the phosphate reabsorption in the PCT. So it causes increased loss of phosphate in the urine, which is known as a phosphaturic action. So that is how the plasma phosphate level will show you a decrease. And how does it increase the calcium level? It causes increased calcium reabsorption in the DCT, right? So it increases the calcium reabsorption or reduces the renal excretion of calcium. So there was one option where both, by increasing the osteoclastic activity and decreasing the renal excretion of calcium. Both were given, so that is the answer to this question. Right, so I'm sure this also, most of you should have got it right? So it increases calcium reabsorption. Parathyroid hormone has a dual action on the nephron. In the PCT, it reduces phosphate reabsorption, which is called the phosphaturic action, and in the DCT, it increases the calcium reabsorption. Right. Then the next question is the motor supply of the muscle spindle is which of the following? Now, in my class, I make you repeat this particular point again and again. What is the motor supply to the extrafusal muscle fibers and what is the motor supply to the intrafusal muscle fibers? Intrafusal muscle fibers are the muscle fibers inside the muscle spindle. And this is one question which I'm very fond of, and I keep repeating this in my class. And that is motor supply to the extrafusal muscle fibers, which are responsible for a muscle contraction. That is A alpha. The motor supply to the intrafusal muscle fibers, which are inside the muscle spindle, is A gamma. There are two motor neurons. The larger one is A alpha and the smaller one is A gamma. A alpha supplies the extrafusal muscle fiber and is responsible for muscle contraction. A gamma supplies the ends of the intrafusal muscle fibers. So the motor supply to the muscle spindle is A gamma. And I keep telling you this as well, that muscle spindle is a very unique receptor, that it has sensory fibers and it has motor fibers. The sensory fibers from the muscle spindle are 1A and 2, and the motor supply to the muscle spindle is A gamma. Okay, so let's go on to the next question. In the adjoining image of the muscle fiber action potential, the phase marked B is due to which of the following? So A is the depolarization phase, And this is because of opening of voltage-gated sodium channels, which results in a sodium influx. What is the repolarization phase? B is the repolarization phase. And this repolarization phase is due to closure of the fast voltage-gated sodium channel, so a decrease in the sodium influx, plus opening of the slow voltage-gated potassium channels, so increase in the potassium efflux. Right? So let's look at the options. It says, is it because of efflux of potassium? Definitely. Is it because of influx of potassium? Now, please understand, whenever a channel is open, channels are ion specific, right? And whenever a channel is open, that particular ion will always move from its higher to lower concentration. So if a potassium channel is open, like in this case, a voltage-gated potassium channel, potassium will move from inside to out, from higher to lower concentration. You have a higher concentration of potassium inside the cell, lower concentration of potassium outside the cell. So it's always an efflux of potassium through voltage-gated potassium channels. Of course, movement of potassium from inside to out, that means against a concentration gradient, will involve a pump, the sodium-potassium pump, right? But through a channel, influx of potassium is not a possibility. And similarly, sodium efflux. If a sodium channel is open, sodium will come from outside to inside. There is an influx of sodium. For efflux of sodium, that means to move the sodium out of the cell, you need a pump. So, sodium efflux is not the answer. Calcium is not the answer. The answer here is repolarization is because of efflux of potassium from inside to out, causing loss of positive charge and the repolarization phase. Repolarization phase, like I said, is due to a decrease, closure of sodium channels and opening of the slow voltage-gated potassium channels. Answer to this, efflux of potassium. Right, so again, I think most of you have got it right. Yes? All right. Let's look at one of the classes, the depolarization and the repolarization of the action potential. Okay. Then you also had a question on pacemaker potential. Now, these are extremely important topics. These are PYTs and also PYQs, the action potential in a nerve, in a muscle, in the skeletal muscle, in the cardiac muscle, and also the pacemaker potential in the heart. Now, pacemaker potential, phase 0. The pacemaker potential, phase 0 is, which is the depolarization phase. This is not due to sodium, but in fact due to calcium. There are two tissues where the depolarization is due to calcium, and that is the pacemaker cells and the smooth muscle cells. Neuron, skeletal muscle, cardiac muscle, the depolarization is because of sodium influx. But the pacemaker cells of the heart and the smooth muscle cells, depolarization is because of calcium influx. So the answer to this question becomes calcium influx. Right. Let's look at the next question. The graph given below shows the normal FEV1. So you've got force expiratory volume of air at the end of 1 second. This is the normal graph here. And you've got the forced vital capacity. So FEV1 and the FVC curves for a normal lung and a diseased lung. How much is normal FEV1 by FVC ratio? This is 0.7 to 0.8 or 70 to 80%. This is a normal FEV1 by FVC ratio. Now, what you see in this graph, which is given in red, what has happened to the FEV1 has reduced. The FVC is normal. So that means what has happened to the FEV1 by FVC ratio? The numerator has decreased, the denominator hasn't. So what has happened to the ratio? Reduced. And FEV1 by FEVC ratio will be reduced in an obstructive lung disease. And the obstructive lung disease here would be COPD. What happens in a restrictive lung disease? FEV1 by FEVC ratio is normal to increased. This is obstructive lung disease. FEV1 by FVC ratio is reduced. Why is it reduced? Because the numerator decreases more than the denominator. In obstructive lung diseases, rates are affected more than volumes. FEV1 is a rate. FVC is a volume. FEV1, why do we call it a rate? Because it involves time. It is a forcefully expired volume of air at the end of 1 second. So it involves time. So it is a rate. FVC is a volume. So in obstructive lung diseases, rates are affected more than volumes. Numerator decreases more than the denominator. Therefore, the ratio reduces. What happens in restrictive lung diseases? Restrictive lung diseases, the decrease, both the FEV1 and FVC will reduce, but the reduction in FVC is more than the reduction in FEV1. Here, the denominator reduces more than the numerator. So, either the ratio will be normal. If both have reduced to the same extent, ratio remains normal, or the ratio will increase if the decrease in denominator is more than the decrease in the numerator. So, what happens in restrictive lung diseases? Restriction and expansion, so volumes are affected more than the rates. Again, FVC, which is a volume, will be affected more than FEV1, which is a rate. Right. So, next. Which of the following is incorrect about baroreceptors? So, I'm not very sure about the recall, about the options. Now, these are the options which have been given to me. And so this is, I'm not 100% sure of the options because there is sort of a, there are different options which have been given, but I think, now which of the following is incorrect about baroreceptors? Is it located in the thick muscle layer? You have the tunica interna, tunica media, which has the muscle, and the tunica adventitia. And baroreceptors are in the tunica adventitia, not in the muscle layer. Are they stretch receptors, which is true? The afferent fibers from the carotid sinus. Where is the carotid sinus? Carotid sinus is in the internal carotid artery, just above the bifurcation, in the adventitia of the internal carotid, just above the bifurcation. So the fibers, the sensory fibers from the carotid sinus will pass via the glossopharyngeal, which is true. From the aortic arch baroreceptors, the sensory fibers or the afferent fibers will join the 10th nerve. Are they sensitive to changes in arterial pressure? Which is true. These are mechanoreceptors. These are sensitive to stretch. These are stretch receptors. They are mechanoreceptors, stretch receptors. So yes, they are sensitive to changes in arterial pressure. So the best answer here appears to be A. AC appears to be incorrect, not in the muscle layer, but in the tunica adventitia. Now, remember, whenever there is an increase in the mean arterial pressure, there is an increase in the stretch of the vessel wall, which increases the firing rate of the baroreceptors. And what is the reflex response? Reflex response will be, it reduces the sympathetic discharge to the cardiovascular system, increases the parasympathetic discharge, both of which result in a decrease in heart rate and a decrease in blood pressure. So this is a negative feedback mechanism which helps to maintain the blood pressure. On the contrary, what will happen if there is a fall in the mean arterial pressure, reduced stretch of the vessel wall, decreased firing rate of the baroreceptors, which increases the sympathetic discharge, reduces the parasympathetic, causes an increase in heart rate and an increase in the blood pressure. So this is a negative feedback mechanism for regulation of blood pressure. Right. Now, which of the following occur during a cough reflex. Now, as far as the cough reflex is concerned, I'm not sure about what are the other options, but this is definitely, which was told to me, forced expiration against a closed glottis, or was it forced expiration against an open glottis? Now, which of the following occur during a cough reflex? Now, what happens in a cough reflex is, initially there is a forced expiration against a closed glottis, and that increases the intrapleural pressure. Now, if you remember from your theory class, the intrapleural pressure is always negative. It's only when I do a forced expiration against a closed glottis that the intrapleural pressure becomes positive. So initially, during a cough reflex, there is a forced expiration against a closed glottis, but then suddenly the glottis opens, and because of which air is pushed out of the lungs at a very fast rate, and which helps to clear the airways. So this is what happens in a cough reflex. Whereas what happens during sneezing? During sneezing, the forced expiration is against a continuously open glottis. So here my best answer, because the question has said what occurs during a cough reflex, my best answer here would be forced expiration against a closed glottis, because like I told you, what happens here? There is a deep inspiration followed by forced expiration against a closed glottis, and this is then the next event to occur is a sudden opening of the glottis, producing an explosive outflow of air with velocities up to 600 miles or 965 kilometers per hour. And what happens in sneezing? This is a similar expiratory effort with a continuously open glottis. So the best answer here would be forced expiration against a closed glottis. Let's have a look at the next question. Now this says, first part of the PCT has which of the following transport proteins? I got 3 options and they appear to be correct, and that is sodium-potassium pump, which is true. The basal side of the PCT cell has the sodium-potassium pump, which pumps out 3 sodium, brings in 2 potassium. So sodium-potassium pump is definitely present on the basolateral membrane. Is there a sodium-glucose co-transporter? Which is true. Sodium and glucose move into the cell by a secondary active transport, which is also known as co-transport or symport. Is there a sodium-hydrogen antiport? Which is also true. Sodium will move into the cell and H+ ions move out of the cell. So that is a antiport. Sodium, hydrogen. So all 3 are present. Unfortunately, I do not know what are the other options, and since this was multiple correct, all 3 options are correct. These 3 proteins are definitely present in the PCT. Let's have a look at the next question. Now this says 2,3-BPG. 2,3-BPG is a byproduct of the glycolytic pathway. This binds with which of the following? Now 2,3-BPG and oxygen bind at the same place on the beta chain of hemoglobin. So it binds with the globin part of the hemoglobin. Beta chain is the globin part. So it binds with the beta chain of hemoglobin. And what are the conditions which cause increase in 2,3-BPG? If there is an increase in 2,3-BPG, this causes a shift of the oxygen-hemoglobin dissociation curve to the right. And rightward shift means FDR, favors delivery or dissociation, a shift to right. So by increasing 2,3-DPG, there is a shift of the oxygen-hemoglobin dissociation curve to the right. And what are the conditions which can cause increase in 2,3-BPG? And Gita, whenever there is excess of growth hormone, exercise, excess of thyroid hormone, anemia, high altitude and whenever there is excess of androgens. So these conditions will increase the 2,3-BPG. They increase glycolysis and therefore there is increase in 2,3-BPG. More 2,3-BPG, that means less binding with oxygen or more delivery of oxygen. So remember, increase in 2,3-BPG will cause a shift of the curve to the right, which favors delivery or dissociation. So these were your physiology questions in today's INI-CET. I hope that you got these correct. My best wishes to each one of you, and hopefully we will see excellent results from you all. And thank you very much for being a part of today's session. Thank you and God bless.